Hey guys, just a reminder that whether you're one of our residents on rotation learning point of care ultrasound or you're part of the FOAMed community looking for another resource on emergency point of care ultrasound, this website and these videos are designed to be used with your mobile device, with your smartphone. So if you just log in to the website, to the home reference page, it is set up to work on your smartphone device. You don't have to log in, you don't have to click. Your smartphone just simply becomes a point of care pocket guide, like the old paper references that you can use while you are learning the scans with the videos or while you are at the bedside learning with the patient. So I hope this helps you. Let me know if it does. Also, using the smartphone device as the reference page allows you to maximize the window, which will zoom in on the videos nicely and allow you to see all the pathology I'm showing. So there you go.
Hey guys, Justin Stowens here again in our trauma bay with two of my med students who are volunteering here to be my guinea pigs to show you guys how to do the fast scan. We're again here with our Titan Sonocyte machine and I'm going to run through it quick and show you how this works. So we're again using the curvilinear probe. The first view here is the subxiphoid view. Remember, we're going to do the subxiphoid view because we care about fluid around the heart first, and because of the depth settings. The depth settings are usually greatest for the heart, and so you make as little change in your depth settings throughout the whole scan as possible, saving time. So by starting out deep, you don't have to go deep, then shallow, then deep again. So here is his heart. Remember, we're answering 3 questions in the subxiphoid view. Is his heart beating? Clearly it is. And is there fluid around it? We don't see a black hypoechoic fluid collection around the entire pericardium. And we get an idea of his squeeze, which looks good. As you do more scans, you'll get an idea just generally of how good a squeeze the patient's heart is. So again, the depth is set so you can see the entire pericardium, no fluid around it. That's the subxiphoid view. We will then move down to...
So here's a pretty good example of some subxiphoid pathology. We've got a heart that's beating. It's not beating anywhere near as well as our young healthy med student's heart. And there is a anechoic or black wedge of fluid around the heart in the pericardium. And in this case is actually causing some hemodynamic compromise, causing some hypotension. It's got some tamponade features that we'll go over in later video lectures in the cardiac series. But for the trauma bay, in the acutely hypotensive traumatized patient, this is a positive fast, and the right setting leads to a ED thoracotomy to drain the fluid. Here's a second example of a heart in the trauma bay in a hypotensive patient. And as you can see here, the heart is beating and it does have a slightly diminished squeeze overall. And you'll notice there is a pericardial effusion here, a small anechoic line that was initially missed on our first look. And it does bring up the question of how small an effusion or how large an effusion does it take to really cause tamponade. Remember, the heart can suffer a great insult to the pericardial sac. I mean, it can take 1 liter to 2 liters of fluid if it accumulates very slowly over time, while most textbooks are going to tell you that it will start to suffer tamponade in the acute setting after only 100 to 150 cc's. So in the right setting with a patient showing tamponade physiology and a moderate-sized effusion in the right trauma settings, these guys are going to get thoracotomies and drainage of the tamponade. On the other hand, in some cases where the effusion is very, very small and likely not causing tamponade physiology, or it's very, very large and the patient isn't showing any other cardiac signs of tamponade physiology, it may take a couple more windows and a little bit more of an exam along with your clinical acumen to decide whether or not the tamponade or the fluid around the heart is actually causing the patient's hypotension.
Down to the right upper quadrant, and notice again I'm in a coronal plane. Indicator is to the patient's head. In the subxiphoid view, the indicator was to the patient's right.
And I just want to take a quick second here because I find this is a hard view for some people to really visualize. This is a coronal plane, right? So like I'm showing here in the picture, you're slicing the patient in that anterior posterior plane, and therefore on the screen the liver is to the left and the kidney is to the right, but you're cutting both of those organs also in a coronal plane. So just take a second and really try to visualize this, try to understand this. If you can, the rest of the scan becomes pretty easy, and most of the other views are fairly intuitive if you can understand this one.
Here is the right upper quadrant view, and again you can see on the screen I was deep before, so I'm actually a little too deep here. The spinal stripe is the deepest structure we really care about here, and so I found several structures: the spinal stripe, the kidney, and the liver. The first space to evaluate, again, three things here that we're going to look at. There are three things in every view. The three things here are the Morrison space, which is in between your liver and your kidney. And I will scan through this entire space. By scan, I mean I'm taking the probe and moving it anteriorly. I'm not fanning through this space, but I'm scanning through it. Scan through that entire space looking for black hypoechoic fluid. All we actually see is perinephric fat. We come down here to the tip of the liver. This is also the pericolic gutter, which is a space where blood will collect before it fills down into Morrison space. So that's the second thing, looking at the pericolic gutter. And then the third thing we're going to look for is this spinal stripe stopping where it should, right at the diaphragm. Remember, sound waves will travel through liver, through kidney, through fluid quite well, and they will stop at bone, giving us this nice hyperechoic white line. Up here in what is the patient's thorax, there isn't anything that transmits sound, right? It's just air waves. So it's just air. So we shouldn't be able to see the spine through a bunch of aerated lung. However, if you have a hypoechoic fluid collection, right, fluid will transmit that sound wave quite nicely, and you will see the spinal stripe through. Recent studies show this to be the most sensitive part of the fast for fluid. So three things to look for again: Morrison space, pericolic gutter, and the extension of the spinal stripe. After the right upper quadrant, we're going to...
So here we have a trauma patient with a frankly positive FAST exam. There is a anechoic fluid wedge between the kidney and the liver in Morrison space, and as the image scans more caudad, you'll see a large collection of black fluid in the pericolic gutter. Nothing really subtle about this exam. I do want to take a second to notice here that we didn't scan cephalad enough here to really prove that the spinal stripe did or didn't extend into the thorax. This scan is incomplete, and I'll show you what a positive extension of spinal stripe looks like here in the left upper quadrant in a second.
We're going to move to the left upper quadrant. We're going to look for a lot of the same things. I do want to show you how exceedingly posterior this is. My knuckles are on the bed in order to really get this view, and that's the case in most patients. And here we are, similar to the right upper quadrant. The left upper quadrant has a space between the kidney and the spleen this time. It doesn't have a fancy name like Morrison's. They just call it the splenorenal space. And again, you scan, not fan, through this space, looking for black hypoechoic fluid, which of course he does not have. Second thing to look for, again, just like in the right upper quadrant, the spinal stripe should stop here at the diaphragm. We shouldn't see it continue up into the thorax, just like he does not. The third thing to look for here is actually an evaluation quickly of the spleen. Sometimes in trauma, you'll have a subcapsular injury, and fluid will collect up here under the diaphragm around the spleen, and it'll make the spleen kind of look like a jellyfish floating in fluid. Though not true free fluid in the abdominal space, it is still considered part of the fast and is still a sign of injury that the trauma surgeons are, of course, going to care about, especially in a hypotensive patient. So that is the three things to look for in the left upper quadrant. Last part.
So as promised, here's some pathology in the left upper quadrant. Here, notice that the space between the spleen and the kidney, the splenorenal space, just contains some perinephric fat. There's no fluid there at all. And actually there doesn't seem to be a whole lot of fluid around the spleen itself, but if you look at that spinal stripe in the first couple seconds of the clip, you'll see that it extends up into the thorax and that there is a nice black anechoic wedge of fluid sitting right above that spine, allowing the sound waves to show us the spine in the chest. This is a hemothorax in the setting of trauma.
Of the abdominal part of the fast is your pelvic views. And the three things you're going to look for here are fluid to the sides of the bladder, behind the bladder, and below the bladder. So here I am in a sagittal plane. The indicator is towards the patient's head. And I am going to catch the bladder in a sagittal view, as you can see here. I'm going to rock down. I'm going to find the patient's pubic symphysis, which is a bright white line through which no sound travels. All you get is artifact down below it. There's no sound waves transmitting, which is great because in a patient whose bladder is totally collapsed, you can still get your landmarks that way. So here I am. I'm in midline, and I'm going to take the probe and I'm going to scan, again, not fan, laterally, both ways. And on the screen, you're going to see I'm scanning from the midline laterally. The bladder is going to go away. You get pelvic vasculature next. And then as you go further, you end up with your iliac crest. You know, you've done the whole pelvis that way. And again, back to midline. And again, now I'm moving to the patient's right through the entire bladder. Again, we get some pelvic vasculature. And then your iliac crest. So make sure during the pelvis, you've done two things. The first, since we've actually recorded this a couple of times now, we've actually already fixed the gain. Usually the far field gain looks the far field of the image looks like this. As the sound waves travel through the bladder, they don't get absorbed. There's no attenuation like there is up here amongst the other tissue. So all the tissue beyond the bladder is seen by the computer system as having a higher energy to it, so it's brighter. It's not attenuated. So you have to kind of correct for that. You have to be smarter than the computer and turn down the far field gain so that you don't miss a hypoechoic collection of fluid in this area. Make sure you're looking at the area around the bladder, right? That's the actual area where fluid is going to collect in the FAST scan. And don't focus on the bladder itself. It's kind of boring.
So as sometimes will happen in live recording, life gets in the way, a trauma gets a run, and we have to leave the bay pretty quickly. In this case, when we came back to the bay, we picked up with the thorax scan, and so I'm going to show you the second half of the pelvic scan here on this digital image. The indicator goes to the patient's right, and we will fan through the pelvis, looking again around the bladder for free fluid. As you can see in this normal scan, the bladder's in the center of the screen. It's anechoic. You can see a little bit of posterior acoustic enhancement of the tissue below the bladder, since I've not turned down the far field gain yet. And looking to the left and right of the bladder as we scan through it, we don't see any sharp anechoic fluid collections that in the setting of trauma would be considered blood. So here's a sagittal view of the bladder. You can see that we're not getting great contact with the patient's skin on the right-hand side of the screen, but on the left you can see the bladder, and just anterior to it or just to the left of it, a nice hypoanechoic fluid wedge. So now we'll see the bladder in cross-section, and as we fan through it, again you'll see fluid collections in the upper right-hand side of the screen and around the bladder edge itself. This is the same bladder done in cross and positive FAST scan.
Done with the entire abdomen. Let's move on to the chest. We're going to rule out pneumothorax very quickly. Of course, our scan has already really evaluated the two lower parts of the hemithorax for fluid in the right and left upper quadrants. Now we're going to look for pneumothorax, and we're going to start in whichever side of the chest is most affected in the trauma, right? If they've got bruising or they've got pain on one side, you want to start there to get the information earlier. But there isn't a true protocolized left or right to start with. Just start where it makes sense. The screen here, we're going to zoom way out. And we're going to get, since we're in the sagittal plane here, we're going to get a rib through which no sound waves travel, and we're going to get another rib, and the space in between is what we care about. This is the pleural interface, and as you can see, as our patient here breathes, you can see a little motion there. Go ahead and take a deep breath for us, in and out. There you go. Looks like ants marching on a line, right?
Well, as cool as the GoPro camera is, the image is a little difficult to see without zooming in. So here it is. This is the sagittal view of the patient's left chest. You can see the rib in the center of the screen, big black circle. That's a rib cut in cross section, and you don't see any tissue down below it. It's blocking the sound waves. And then you can see the hyperechoic moving white line, which is the pleural interface, just below it here. And as the patient breathes, you'll see this line slide to the left and to the right. That's normal lung slide. You'll also see what they call comet tail artifact. Every once in a while, you'll see a little shimmer of light. It looks like a shimmer of light. It's actually artifact caused by the sound waves passing through the little bit of pleural fluid that's there. They call that comet tail artifact. And again, that's a normal sign of good lung slide. There's no pneumothorax here.
That's good lung slide and a sign that the patient does not have a pneumothorax. Some cases you can't really see this quite well. Motion is difficult to see due to whatever's going on in the patient's chest. You can use M mode, which drops an M mode spike through the center here. Hit M mode again. Take a deep breath for us. And you might get an image that looks like this. This is called the sand and sea sign. This part being the sea, looks like water, looking down from above at the beach, and this looks like sand from the beach. This is a lack of motion through the tissues of the chest, the muscle, the bone, and then this is the lung tissue that's moving, right? So there's motion there. That's why it looks all speckled when you look at it in M mode. A positive fast would have what they call a stratosphere sign. The whole thing looks like the sea. It looks like just lines like up in the stratosphere. And that means nothing is moving, including the tissues down here in the lung where it should be moving during breathing. So after you've done the patient's, in this case, left chest, you move on to the patient's right chest, and you do the exact same thing. And there you go. Again, here you can see good lung slide. So this guy has good lung slide bilaterally, and of course you could do M mode again if you wanted to here. And again, we can see sand and sea as he breathes.
So here's a patient with a pneumothorax. Again, you can see two ribs on either edge of the screen with the pleural interface in between. And as this patient struggles to inflate their chest, you can see there's no slide there. You'll see a little bit of what looks like tugging. You'll see some of the tissues sliding with the bone. The whole chest wall is kind of moving, but that nice pleural interface has no slide. There's no comet tail artifacts. There's no motion there. This is the sign of a pneumothorax. We will go over pneumothorax specifically in the lung section of the website, so stay tuned for more of that coming later.
So there you go. That is the extended fast scan. There, of course,
lots of nuances that will require practice and lots more to learn about the fast scan than I could show in this video. So keep practice your scanning and send me lots of questions, and as always, send me requests for more videos and specific topics you guys want to see.